and gentlemen, welcome to you all today to my topic, A Bolt from the Blue. This is Dr.CM.Kudrat E Khuda, Assistant Professor Cardiology and ICVD. This is the background of my patient named X, age 55 years, gender male, business occupation, and he was admitted to our hospital on 14th October 2022. He was presented with with exertional chest pain for 2 months, and the risk factors associated are diabetes mellitus, hypertension, ex-smoker, and family history of ischemic heart disease. His past medical history was he was admitted with acute anteroseptal STMI on 17 July 2022, and at that time he was not thrombolized due to delayed arrival. The general examination and systemic examination reveals no abnormality, and the baseline investigation is normal, except RBS is quite high. This is his ECG. There's a pathological cue in V1 to V3. That means it was OMI anteroseptal. Chest X-ray reveals normal. Echocardiogram shows mid and distal IVS and adjoining apex, and mid anterior wall moderate to severely hypokinetic. Moderate LV systolic dysfunction, good RV systolic function, and no pericardial effusion. So our diagnosis is chronic coronary syndrome with old ST-elevated MI, anteroseptal with diabetes mellitus with hypertension. Then we did the CAG. CAG shows in LAD osteoproximal 95% stenosis and proximal 99% stenosis, and in the LCX, the distal part having 70 to 80% stenosis. And in the LM, distal LM has 60 to 70% stenosis, but it seemed to be an ambiguous lesion in the left main. And the CAG right shows proximal PDA has 99% disease, retrograde flow from RCA to the left system. So our CAG impression was left main triple vessel disease, and we did a syntax score that was 24. So as there is an ambiguous lesion in the left main, we had a plan to do an OCT. Then we did the OCT. This is the OCT run-through show. That is, now we are in the proximal distal LAD, and now we come to the proximal LAD. And when we entered the proximal LAD, we saw that there are thrombus along the course of proximal LAD, all the way thrombus along the course of proximal LAD. And when we entered the left main, and we see a big dissection flap in the left main. This is the still picture of my OCT. At the right plane, we see the dissection flap in the left main, and in the left plane, we see the thrombus in the left main, proximal LAD. So we had a plan to PCI to left main to LAD. Basically, this wiring and pre-dilatation was done before the OCT. The wiring done across the lesion, and the pre-dilatation using 2.5 into 12 millimeter NC-track balloon at 10 atm pressure. And after pre-dilatation, now LAD is visible. Previously, basically previous wire was diagonal. So we negotiated another wire across the lesion through LAD. And then a drug-eluting stent is placed. And drug-eluting stent 3 into 30 millimeter is placed at the proximal left main to proximal LAD and deployed at 8 ATM. This is Resolute Onyx. Then the post-dilatation was done, balloon dilatation of the lesion sequentially by 4 into 10 millimeter Sapphire to NC balloon at 12 ATM and 4.5 into 12 millimeter quantum apex NC balloon at 12 ATM. And for querying the how stent is expanded or opposed, we did OCT again. This is the OCT run-through view after stenting. This is the distal LAD. And we are coming near to the stent. And at the stent area, we see that there is no edge dissection. Starts as seen, so the stents are well opposed. and well expanded along the left main to the proximal left main to the proximal LED. And this is the fly-through view of OCT. Here we have a very good quality view of the stent deposition and expansion. And here we can see that stent is well apposed and well expanded, and there is no edge dissection. So this is the final angiogram view. It shows successful stenting at proximal left main to proximal LED, and TME3 flow is achieved. So my take-home message is OCT allows for superior ability to characterize plaques, provide detailed information about the vessel, follow-up of coronary stenting, can visualize spontaneous dissection, recognize new intimal hyperplasia, and OCT in left main PCI enhance planning, executing, and optimizing intervention. 3D reconstruction for OCT will likely have an increased role in optimizing main vessel and side branch as well as stent deployment. This is our NICVD Unit 14, where I'm working under Associate Professor Mohsin Ahmed sir. And thank you very much, and happy Independent Month to you all.